So I'll quickly run through my presentation, which is the post-RK IL power calculations. Currently we know RK is hardly performed, or to be exact, not performed nowadays, but this is the scenario when we are getting most of the post-RK patients as compared to most of the post-LASIK patients. Nowadays we are getting most post-RK patients who have undergone the RK surgery 20-26 years back, and now they are coming to us for IL power calculation, and obviously they are also demanding emetropia. So, I have no financial interest in any of the products mentioned. So, what are the challenges in a post-RK patient? Is basically, Ridhima has mentioned, we have the change in the anterior and the posterior curvature both. We have very small optical zones. These are biomechanically weaker cornea as compared to LASIK, and obviously there are chances of opening up of the RK cuts during the surgery, and obviously higher chances of refractive surprise due to swelling up of the wounds. So that's why it actually demands a better attention. So in a post-LASIK we know there is only the flattening of the anterior curvature. In a post-RK there is flattening of the anterior and the posterior curvature both. Assessing true power already been discussed. We have historical method, we have hard contact lens method, we have values derived from the standard keratometry and corneal topography. But obviously values derived from these will lead to an hyperopic error again. Historical method is limited by availability of data, which will be like 20-26 years back, where I am not even sure whether they would have done a topography at that time. Hard contact lens method is usually limited because the visual, if there is severe visual impairment, it won't be helpful. Most of the simulated topography maps and actual topographic values invariably will lead to an hyperopic shift. So we know that true corneal power is not the only thing that's required. We require the P of K values to adjust the effective lens position and to get an exact IL power calculation. So what do I do in these cases further? Now we know that as per the earlier discussion, we have K values, we have the K values, we have the effective lens position calculation. We have to check for spherical aberrations for all patients. Now which lens to put, spherical or aspheric lens? Whether we should have done a toric lens in a post-RK patient. What incision should I take? Should I take a lingual incision or should I take a scleral incision? That's important. Should I go for a multifocal or should I not go for a multifocal? Well, all those questions will be answered shortly. Spherical aberration, clearly mentioned earlier also, there will be increase in the spherical aberration. Can we go for toric lenses? Well, in the post-RK patient, it is mentioned in many of the papers that the astigmatism is mostly irregular and toric lenses are used to correct only the regular astigmatism. If you have a high irregular astigmatism, perhaps toric lenses will not give you that particular benefit. It can be considered that the astigmatism is regular on topography. The cuts are fewer than perhaps 8 cuts, and the optical zones are larger, which we hardly get with post-RK. And always try to correct at a toricity. If you have a minimal amount of astigmatism, for even example, if you correct normally in cataracts you correct more than 0.75 or more than -1, here give it a larger value. Even if you have a cylinder of around 1 to 1.25, just make an incision in the steep axis and still you will get away with that. Where do I take my incisions? If you have enough space in between, well yes, go for a clear corneal incisions, hardly any seam. But if you have something like more than 8 cuts, you will perhaps be happy with a lingual incision, which is also associated with fewer chances of opening up of the wounds. Multifocal or not, it has limited role. Optically compromised, highly compromised cornea, you have small optical zones. There are some case reports published which say that good outcome in cases limited to only 4 cuts, larger optical zone, and obviously absence of an irregular astigmatism. Only in these cases you can think of multifocal, otherwise not. So I'll briefly run through 2 case examples. My first case was a 52 male, actually done 26 years back. RK pre-op refraction he says was -3.5, and he says immediately after 2 years he got a refractive error of -7.5. We don't know the lens status. Now current refraction he comes to me, it's this -10.75 with -0.75 cylinder. He has a nuclear sclerosis. This is a topography map. This is a series which I have. It is based on the Placido with shine plug. This is an initial anterior map. I need you to see this map very clearly because I'm going to discuss this further. These are the K values as given by the topographer. I do pupillometry in all the patients because the mesopic pupillary size you take, accordingly you take your spherical aberration in the mesopic pupillary area, and it helps you to select your which aspheric lens or spherical lens you want to put. Spherical aberration measured on this data using the mesopic pupillary size is 0.22, which is fairly good for such kind of post-RK patients. Refractive equivalent power is already been explained by many by all here. So this is the refractive equivalent power which this map gives. This particularly gives me what is equivalent to the 65% mean of a pentacam. So basically, if you have any machine which works on the Scheinfeld principle, will give you this kind of value in all topographers, which gives me a mean value in 4 millimeter zone, which I have taken here. The same calculator. This is the post-RK one. So all those formulas which were shown earlier don't appear here. I'll take few minutes here. Effective refractive power already explained. Average central power is basically the ACCP of TOMI and nothing else. At last we know 1, 2, 3, 4 already discussed. This is something addition into it. The value which Karishma and Varun were talking about, the 65% mean, you can directly enter here. You put the minimal corneal thickness. You put your IOL master or lens star values of K values. If you don't have, just put the topographic value what we have got. Enter the immersion axial length, enter the A constant, and you can still get away with a good IOL power calculation. So in this case, I got a result of around 4.3. Fairly tight. I just implanted a lens which is of 5 diopters, absolutely uneventful paper emulsification. And what I land up here is a plus 2.25 with a 1.25 cylinder. So at this point I thought, okay, hyperopic shift I know, but let's see how much it is going to improve. Patient was highly demanding. So I just told him this is something which is known, already explained to the patient in hand. So he was calm and he was looking up, it will improve over the time. So we know there is variable amount of hyperopia in the immediate post-operative period. Flattening is usually transient and it can be as much as 4 diopters. And if the cuts are more, the optical zone is less. If the cuts are deeper, it will be still more. But we have really not documented how exactly it looks on a topography. So I will take you, I would like your attention to on these 2 points. We will look at 38 and 42. My incision was temporal, 38 and 42, which after the surgery becomes 38 and 39. So normal surgically induced astigmatism would be around 0.5 to 0.8. In this case, it went flat 3 diopters, which explains us that in these cases the flattening is little more. So this was day 1, which becomes 39, 40, 41 point something to 38 and 39. I waited for 1 month post-operative, bounced back a little bit, 38 and 40. I waited for 3 more months, comes down to 38 and 41.3, very close to what it was pre-operatively. Explains to me, actually it is very transient and it takes a time of around 3 months. In my next case, it came up to around the same emetropic power within like 15 days, but in this case it took 3 months. So this is the next case. This is case, see Dr. Ridhima, she gave me this case because I wanted to use 2 different machines to show you. The post-RK patient done 20 years back. Now I want you, she had IOL master calculation. And if you see here, the value here I want you to notice 21.2 for IOL, this what is given this machine. I have the pentacam, I have the EKR value, I have the 65% mean, which I just put in a post-RK calculator as earlier told. I put the K values from the IOL master, and I put the axial length, I put my A constant. So I get a very tight power, and if you see, that's exactly what Dr. Varun mentioned, that if I have an IOL master value, but if I put this in calculator, it is giving me 2 diopters more than what it was showing in the IOL master. In this case, she planned for a toric lens because there was a 2.2 diopter astigmatism associated. The surgery was absolutely bang on, and this I would like you to show the same thing. On day 1, a hyperopic shift. This is like 19th April, and within a week it reduces to 0.75 to -1. At day 15, very happy she was. It was like almost emetropic 0.5 with a -0.5. But after 15 weeks, we see it's a minus 0.5 to minus 1, and it's settled down at this particular thing, which is still very good outcome considering the post-RK status and the post-Toric IOF. So what are the take-home messages in the post-RK patients, which are going to get more and more these days? As the optical zone is much smaller, be prepared for hyperopic surprises. Target a little myopia, limbal incisions are preferred. Proper patient counseling is most important. Consent should include the possibility of gaping of pre-existing scars, refractive surprises, and the use of sutures. You have to explain to the patient that the fluctuation of vision caused by the RT cuts will not be gone after the cataract surgery, and for that matter, any glare or halos which persisted will still remain after the cataract surgery. So on all this, I would say today what is the armamentarium which is required for achieving this is a topography, an aberrometry, and a biometry A scan, which we call it as TAB. So to summarize the instruction course here, these require IL power calculation. Compromised corneas definitely require special attention. Counseling of the patient is most important. Unrealistic expectations of the patient should be carefully addressed. Thank you very much. We have lots of time to take any of the questions, so if any questions, do let us know.